Hello, everyone. This is Dr. Siddharth Tambar. Welcome to our webinar today. Physician here at Chicago Arthritis and Regenerative Medicine. Before we get started, if somebody in the audience can please either raise your hand or just signal whether you can hear me loud and clear on the audio as well as the video, please. Okay, so I'll get started here now. We're having a little bit of okay, thank you very much for giving me that feedback. As we get started here, we have a little bit of technical issues in the sense that I don't have my PowerPoint slides today, but you know what? We'll do our best here. As I have any questions, or as you have any questions, please shoot them in and I'll continue to answer them as we go along. So in today's webinar, we're talking about what are the best available non-surgical treatments for arthritis, tendinitis, injuries, and back pain that do not require surgery, but rather utilize your own cells. What is legitimate in the field of regenerative medicine, and how to choose the best physicians and clinic for your procedure if required. And at any time as we're doing this, okay, great, thank you. If there are any questions that are either, please put in your questions in the chat, but after we're done, if you have any remaining questions, please feel free to email us, call us, or contact us via any of our social sites. We are always here to answer questions and available to help out any way possible. So the big questions are, what would you do if your pain was controlled? How would your life improve? What exercise would you restart? And what activities with family and friends would you start to participate in again? So a little bit about who I am. My name is Siddharth Tambar, physician here at Chicago Arthritis and Rheumatology, specialist in rheumatology, as well as specialist in image-guided musculoskeletal injections and regenerative medicine, in practice since 2008, and practicing regenerative medicine since 2008 as well, and within the Regenerative Network since 2012 as well. So the Regenerative Network, by the way, is a group of physicians around the country who are involved in regenerative medicine and essentially utilizing similar protocols, sharing results, and trying to get the best outcomes for our patients. I just saw a question come up. Thank you for the question. We're not currently doing cervical spine and thoracic spine treatments. We are still referring those out at this time. Okay, so my personal journey into regenerative medicine really starts with my own shoulder. Essentially, I played a lot of tennis and some swimming when I was a teenager. Never really had a shoulder problem. However, in my medical training, I was taught musculoskeletal ultrasound. And in studying my own shoulder, I came to realize I had some instability, some mild rotator cuff issues. None of those things were really painful at the time, but as time went on, and as I got older, I started to develop some more discomfort and issues in my own right shoulder. And so that whole process of realizing that there's a lot more to tendon and ligament injuries than maybe what I've been taught in my medical career or what I've been taught in terms of treatment for musculoskeletal issues made me start looking for other and better options for my own patients. So when I started practice in 2008, realizing that I have patients who are having a lot of these kind of issues, I essentially started to look for other options. Initially, platelet-rich plasma and prolotherapy, and then after a few years, and involving bone marrow-derived stem cell treatments as well. So the traditional care for either arthritis, tendinitis, or back pain, it's very archaic. The example of that in, let's say, other realms of medicine would be if you had a diagnosis of diabetes or high blood pressure. And instead of trying to treat that, your physician just said, why don't we wait until you have your first heart attack or stroke? Nobody would do that now. Maybe that's what happened decades ago, but realistically, musculoskeletal care, orthopedic care is still built on that model, which is, okay, let's just try to cover up the pain until you finally need some kind of very dramatic surgery. So the problems with traditional care, besides the fact that they're very ridiculous in terms of long-term health, are the typical non-surgical options are either pain medications, which don't fix the problems and have plenty of side effects. Narcotic medications fall into that as well, and they have a lot of side effects. And the traditional injections, such as steroid injections or nerve blocks or radiofrequency ablation treatments, can give short-term pain relief, but are really not very good or helpful when it comes to the long-term nature of your musculoskeletal health. They can damage tissue. They're not really healthy for you long-term. Surgery has a role in more advanced conditions, but it is overused. To begin with, surgery compared to non-surgical treatments are higher risk in terms of bleeding, infection, anesthesia risk, cardiac risks. A lot of traditional orthopedic surgeries, including things like knee arthroscopy or even shoulder arthroscopy, can actually accelerate the arthritis process because they lead to more instability. And in fact, even when you look at knee arthroscopies in the setting of wear and tear arthritis, what you find is that they're no better in studies compared to just physical therapy or sham surgery. And so for those of us involved in regenerative medicine, who've been doing this for a while, really strongly feel that 80% of musculoskeletal conditions that are currently going to surgery should long-term actually be going to regenerative medicine and non-surgical options. In the same way that 95% of cardiac surgery has now gone to just needle-based treatments. The same thing will happen with orthopedic surgery. So in searching for better options, these options should be lower risk, they should avoid serious side effects, they should address the source of your problem. And the source of most musculoskeletal conditions is typically either instability and inflammation and sometimes metabolic issues. And if you can improve the actual cause of the problem, you can actually give longer lasting relief, better function, and longer term improvement as well. So imagine reducing your pain and getting back to the activities you care about without surgery or medications. I'm just going to, from time to time, just double check the Q&A and chat sections. Great. So regenerative medicine is the process of utilizing your own body cells to treat your arthritis, tendinitis, injuries, and back pain. So if you think about how your body normally heals after an injury, take something as small as like a cut on your finger. What happens is that you have platelets that infiltrate the area. They first stop the bleeding. They then release growth factors, which then stimulate your own local stem cells, which then start a slow but progressive process of healing. First through inflammation, then bringing in other cells and layering other cells. So this is a really good option if you have good supply in an organ or an area. So the skin is a great option where, a great example of where this kind of healing modality works very well because there's very good blood supply. In tissues that don't have as good blood supply, and that can include tendons, cartilage, ligaments, discs, labra, meniscus. Those tissues are hardy, but if they've been injured long enough or repetitively injured, they can eventually lead to a stage of chronic instability and damage that does not heal very well on its own. So regenerative medicine is the process of taking those same cells that are involved in your normal healing, that includes your own blood platelets and your own bone marrow stem cells, and then under high-level image guidance, injecting those into the tissue that's been damaged. So why regenerative medicine? To begin with, it treats the source of your problem, meaning instability and inflammation. It's safer than surgery. It's effective for most musculoskeletal conditions, and really should progressively take over what is currently being done with a lot of other traditional treatments and surgeries. So when we talk about what's the source of problem, like how does regenerative medicine work, it works in a number of ways. To begin with, if you think about why you develop wear and tear in a tendon or a joint, it's because of progressive instability. So in the normal course of living or physical activity or work or exercise, getting some mild strains and sprains is very typical. right? It's the normal part of being a human being that we stress our bodies in activity, which can then lead to some soft tissue injuries. Normally, from a symptom standpoint, our body recovers from that after a few days or weeks, and then we're kind of back to our normal activity level. The reality is that when you look at that tissue, even though you're not having as much pain because that initial inflammation is down, that tissue is a little bit weaker. So that ligament's a little bit weaker, the tendon's a little bit weaker, the meniscus a little bit weaker, and progressively over time, you can get instability in that area. And that instability eventually leads to more stress on the joint or the tendon, which then eventually leads to that arthritic process, tendinitis, tendon tears, all those other kind of things that happen with wear and tear. And so instability is a key part of this. Regenerative medicine works very well with instability because it's focused on treating not only the joint that's been damaged, but also all those other soft tissue elements. I'll talk about that in a moment. The other thing is that regenerative medicine is good at treating chronic inflammation. So while our treatments cause initial inflammation up front, longer term, it reduces inflammation better than our other non-surgical treatments that are available. By doing that, it leads to a better result longer term. So how does regenerative medicine work? It works because it improves instability. It works because it improves chronic inflammation. It optimizes the cells and the health of the cells in the tissue that's been damaged. And we can also treat some of the other neuromuscular issues that are around the joint as well. So, when we talk about what makes a regenerative medicine expert, that's kind of a key thing that I want you to walk away from this talk. There's a lot of things. To begin with, they should be a musculoskeletal expert. And that means their training and their focus should be on your joints, your tendons, your back. If your physician is sort of, in one room handling somebody's testosterone management, in another room, they're handling somebody's erectile dysfunction, and then they're coming to treat your knee, that's not someone who's really focused on musculoskeletal issues. They're kind of running around doing a lot of different things. Number two, they should be a non-surgical musculoskeletal expert. This is key. Our orthopedic surgeon colleagues are very well trained in surgery. The reality is in medicine, when you focus on one thing, you get good at that. Our orthopedic surgery colleagues don't have the same kind of experience or training when it comes to image guidance for these kind of procedures. So image guidance is very key for all these kind of procedures. If you're injecting a steroid injection, steroid is fat soluble. So you can inject a steroid into your shoulder, and if you've got inflammation in your back, you'll have a little bit of reduction in inflammation. With regenerative medicine, when you're injecting cells, it doesn't work like that. You have to inject directly where the tissue is damaged, and so precisely that if you're not hitting that exact tissue, you're not going to get the right kind of result. In fact, I tell my patients that, look, while I have some colleagues, older colleagues, who will tell you that just by palpating the skin, they can get a sense for where they need to inject. What I tell people is until I have X-ray vision, I am using the tools that we have available, and that includes X-ray guidance and ultrasound guidance to make sure that we're hitting very precisely where it needs to be treated. The next is, physicians who do these kind of treatments, they need to understand how inflammation really helps you heal. The problem is that because physicians get trained in using steroids again and again and again, is that they think that's actually helping the problem. And the reality is it's not. It's actually problematic long-term. So the way traditional medicine works is very opposite when it comes to dealing with inflammation. So your body's normal way of healing is some acute inflammation after an injury to then give you healing to then lead to less inflammation long-term. What happens in most cases, though, is somebody has chronic inflammation because the joint is chronically inflamed and unstable, and then they get a steroid injection, which reduces inflammation temporarily, and then the inflammation comes back. That is the wrong way to treat things. The right way to treat things on the regenerative medicine side is treat with a regenerative medicine treatment, which causes a little bit of inflammation initially, and then leads to longer-term reduction in inflammation. And so not understanding how inflammation works and when it's appropriate and how acutely it's okay and long-term it's not really makes, I think, some physicians treat things with the wrong kind of treatments, whether it's steroids or nerve blocks or things like that. Next is really understanding the different types of biologic treatments that are available. There's a number of different treatments that we utilize, and understanding that one size does not fit all is very key here. And so just because you have a knee or a back problem does not mean you should get treated in the same way as, let's say, the next person with a knee or back problem. Depending on your level of severity, you should get a stronger treatment or less strong treatment based on concentration of platelets. Depending on the severity of issue, maybe you're a better candidate for bone marrow stem cells rather than platelets. So there's a lot of subtlety to these kind of treatments, and a one-size-fits-all kind of approach, sort of a factory approach where everyone gets the same thing, is not the right way to do this. Having a personalized, bespoke treatment plan is the right way that you need to get these kind of treatments. So I've talked about instability a lot. Prolotherapy is a key part of this. I'll talk more about that in a little bit, but treating instability is very key. As well as your physicians really should be very transparent regarding what are the potential results based on actual proven data. That's something that we do within the Regenerative Network. They should also be very clear about your candidacy. Are you a good, fair, or poor candidate? I have colleagues who just sort of automatically will look at an X-ray and say, oh, you're a poor candidate. That's not the right way to think about this. Arthritis is not just a picture on the wall. It's a biologic condition. There's a lot more. It's a functional condition, a physiologic condition. And so, for example, someone who's got advanced arthritis of the knee can still, on average, get a 65 to 70% improvement in pain and function. And so that's something that's not really translated just on how your X-ray looks or gestalt sense of what someone's response will be. That's based on proper candidacy and understanding of these treatments and results. Next, your physician should be following these results long-term. By that, I mean if your physician is just doing a procedure and you never see them again, that's not correct. There is a progression and process to this. Your physician should be part of the process. And lastly, they should guide you through the process. These treatments have been around for a while. They're not new, but the reality is that they're new to a lot of patients. And the reality is that you should be guided by your physician here. Okay, some good questions coming through. I'm going to kind of slowly take these as I go along. How many joints can we treat with one bone marrow aspiration? Such a good question. It really depends on how many cells are obtained from the bone marrow aspiration. For some people, more, some people, they get a dramatically high cell count. For some people, it's a lower cell count. This makes a difference because the amount of cells that you inject makes a difference in large joints in terms of results. In addition, the volume that you can get makes a difference as well. And so if you're treating knees, in general, treating one knee at a time, there's some people where with a bone marrow aspiration, you can get enough to get to treat two knees at the same time. So it just depends. And then it also depends, let's say someone's got two knee problems, is one knee, you're worse off and you're really focusing bone marrow stem cells with that. And the other knee maybe gets a little bit of bone marrow, but more platelets. So it depends on the person and the issue realistically. It's a good question. It's a very technical question. Somebody asking about what type of needle is used for stem cell aspiration. So we use there's a traditional needle that's been around for decades called a Jamshidi needle. It's a needle that is utilized for bone marrow aspirations everywhere. It essentially allows you to get into the right space with very limited trauma and allows you to get a good sort of aspiration. In terms of other needles, there are a lot of other tools that are available online nowadays, but they don't necessarily give you a higher cell count. They may work a little bit differently, but when you actually measure how many cells do you get, you stick with the Jamshidi needle because that's not necessarily you don't necessarily get a higher cell count by utilizing some of these other needles. So next question is, look, how do we treat multiple joints at the same time? It depends on the person. Again, like, do they have something that is bad enough that requires stem cells? Let's say there's someone who wants to treat a hip, which is sometimes harder to treat on its own, two knees and two shoulders. That's a lot of joints. And, do we need bone marrow for all those? Can we just use bone marrow for one or two joints and platelets for the rest? We can do that here in the States. If someone needs sort of multiple cells treated with multiple joints, let's say 4 different joints, treated all with bone marrow, then actually going to someplace like the Regenerative Cayman site where they can expand or culture expand your number of cells might be worthwhile to consider. It's a good question. So some other common questions that I get from patients for regenerative medicine basics includes, is this legal? And the simple answer is yes. There are some very strict guidelines from the FDA these days. And those are, number one, are using your own cells. Don't be using someone else's cells. Number two, are you using these cells for orthopedic conditions, right? That's another key part of this. And number three, so you can't be using them for things like traumatic brain injury, kidney failure, just random other things like that. Like the evidence is for orthopedic issues. Number three is, are you taking the cells and then re-injecting them same day? The idea is that you can't hold on to them for days, weeks, or months, or years on end and then re-inject them. There's concerns about, do those cells get changed over time? Could they be at risk? So there are some potential scientific concerns, but the FDA has some very strict guidelines. And as long as you follow them, yes, this is legal. Another good question is, if you're older, should I use somebody else's cells? For the vast majority of conditions that we treat, the answer is no, use your own cells. There's good evidence that using your own cells is appropriate for most peripheral joints and back issues. The one exception would be the hip, where if you're over the age of 60, 65 years old, you may not get the best response in using your own bone marrow derived stem cells. Still do not recommend using someone else's cells, right? Because there's a lot of risk with that, actually. There's really very limited evidence in using somebody else's cells as safe. And in the US, you cannot do that. Other countries that may be allowed, right? It's kind of questionable about allowed, but I'd be cautious about that, because you can get, just using your own cells, you can get the right outcomes. And even when, there's always a question about, is there an age limit for this? The simple answer is, for everything that we're talking about, no. The one exception is hips, where if you're over the age of 65, hip results can be worse as you get older. And so if you need a larger number of joints, like multiple joints that are treated, and if you have like a hip issue, then using culture expanded cells in the Cayman Islands through Regenix is still a possibility. I still would not go use somebody else's cells where you just don't know the safety associated with that. Okay, some other good questions. We'll get to those in a little bit. Other questions: what sort of doctor performs these treatments? As I mentioned, a physician should be focused on musculoskeletal conditions, focus on non-surgical treatments, image guidance, right, expert, and really a proper regenerative medicine expert that really understands a lot of those other things I've talked about. Can these treatments be used or help if you've already had surgery? Depends on the surgery. If you've had a joint replacement, no, right? Like you've got metal or some other artificial prosthesis there, right? We can't really treat that, although your pain may be coming from a nerve issue and we can treat that. But if you've had, let's say, an arthroscopy surgery or a spine surgery, like these are treatments that can still help. My general rules for orthopedic surgeries is try to keep your own anatomy, avoid surgeries that cut out tissue, always consider regenerative medicine treatment option if you've been recommended surgery. So we talked about key concepts. Stability or prolotherapy is a key concept. I talked about that a bit, about how there's this concept in architecture called tensegrity. And what it means is that if you take individual units that are relatively weak on their own, if you put them in close approximation, compress them, the overall structure is stronger than the individual units together are, or the individual units are. And this concept in biology is called biotensegrity. So, for example, the concept in medicine or in biology is that you take something like a knee joint that has multiple areas that have been dinged up or injured, and if the way to treat that from a regenerative medicine aspect is to treat every layer that's injured. So if you take someone who's got knee arthritis, what you'll find is that there's narrowing of the joint space, a little bit of breakdown of the cartilage. You'll see the meniscus is a little bit frayed. You'll then see that the ligaments on top of it have been kind of stretched or strained. You'll see that even some of the muscles around that, some of the tendons around that have some chronic changes that they've been stressed out. And you'll even see some of the subcutaneous tissue has a little bit of irritation. And so if you treat all those layers and the layers of treatment and depth of treatment, that people tend to do better. In addition, there is something to this idea that you want to treat above and below the joints. So if someone's got a knee issue, Do they also have an ankle issue or a hip issue or a back issue? Just make sure you're being comprehensive in treatment to get the right kind of result. When you do that, what you get is progressive strengthening over time of that joint that then gives a better result long term and a longer lasting result long term as well. So prolotherapy and stability is very key. Some examples that I try to kind of show the people are patient who had some lower back issues and in his 70s, he'd already had 2 laminectomy surgeries, still has back pain, very common issue that we see. In his case, we first did platelet-rich plasma. We injected the ligaments, the facet joints, the muscles, epidural space. That gave him about 40% pain relief and did okay with that. We ended up escalating to using his own bone marrow stem cells, got him more toward the 75% improvement and really just doing quite well longer term as well. The next concept to understand is orthobiologics. These are the cells, the biologic cells and tissues that we inject into damaged orthopedic tissue. I mentioned that there's a normal kind of healing process that involves inflammation, that involves your own cells. That's why we utilize these same cells. Please use your own cells, not somebody else's, for safety purposes, and that's what's proven to work. So we talked about the importance of platelets when it comes to healing after an injury. Platelets really work from a healing standpoint because they help by stimulating your own local stem cells. The growth factors from platelets really start that process by stimulating your local stem cells. And so by utilizing inflammation, it helps with tissue repair. There's different types of platelet preparations. Again, I don't have our slides today to show what some of those look like, but there's different strengths of platelets. The kind of platelets that you should be getting should, number one, be an amber colored, not like a really dark red colored. You don't want all those red blood cells. They're more inflammatory. If you're injecting into a joint, you want to use a very high concentration of platelets. If you're injecting into a tendon, you're using a moderate concentration. If you're injecting into ligaments, you're using more growth factors from platelets. If you're injecting into muscle, you're using more just platelet poor plasma. So there's a lot of variability with the kind of platelet preparation that you should be using. If you're getting a one-size-fits-all, like here's your platelet concentration, that's what it is, you're not getting the right kind of treatment. There should be a lot of nuance to this. And again, apologize for not having some of our pictures here, the next kind of case that I discuss is of an individual who's got patellar tendinitis. He's a 45-year-old man, a cyclist. He's got persistent patellar tendinitis. Despite physical therapy, he's referred to me by a sports medicine physician. We ended up treating his own platelet tendon under ultrasound guidance, using his high concentration of his own platelet-rich plasma. After 2 treatments, he was able to return back to full capacity, including cycling. Did great with that treatment. 3 years later, I saw him for another issue. Now this is in the other leg, tendon hamstring injury. Again, platelets, and did really well. What I like about platelets for a lot of first-line options, especially soft tissue injuries, is that it is a good, low-intense treatment that helps with a lot of mild to moderate conditions and can be layered on like multiple treatments or with some of the other orthobiologic treatments that we utilize to get a really good result. Let me just catch up with some questions here. Okay, somebody asking about combined procedures that combine cells with matrix. Can you explain the difference? Yeah, so there are some other, I'm a fan of utilizing your own cells. And the reason why is because that's where the data is and that's where the safety is. So there are folks who have utilized other types of products, whether that's placental-derived cells or amniotic cells. All of those kind of cases in the United States, to do those treatments legally, the way those cells have to be processed, they are taken from another person, right? Someone donates them after birth, and they are then processed in a manner where there's no more living cells. So they remove the chance of infection. And what you're left with is some growth factors. That's not really a stem cell treatment. It's not a stem cell treatment because there's no living cells. There's some growth factors. There may be some benefit in those treatments for soft tissue injuries, but you can utilize your own blood platelets for that. Like why utilize somebody else's cells? So when it comes to using or combining some of these treatments with some of those other things, maybe there's some benefit to that. There's no data on it. And I think we have enough evidence proven treatments that utilize your own cells, where you don't really have to reinvent the wheel or utilize someone else's cells. Okay, someone else asking, how long must a person wait to utilize regenerative medicine treatment after they've already had a steroid injection in the same area? I recommend at least a month. This is assuming that you're utilizing a typical steroid injection. So a typical steroid injection is a very high dose steroid injection. Those have significant effects on the joint or the tendon that's been treated. They can also affect your overall body's endocrine system. They can actually increase your blood sugars. They can make you more prone to osteoporosis, diabetes, adrenal deficiency. So you want to wait at least a month for that to get out of your system. If you're getting a low dose steroid injection, that means like a millionth of dose steroid injection, that you can get, the next day or even the same day, because it's not going to affect your body the same way. Okay, good question. Should a person ever have another steroid injection area that's been treated with PRP or mesenchymal stem cells? I think utilizing steroid injections, there's a class of my patients that I see that have dramatically inflamed joints, like rheumatoid arthritis, right? That is a different kind of ballgame. But I think if you're dealing with more wear and tear arthritis or tendinitis or back issues, I would try to avoid steroid injections for those areas. They're just not healthy. I think we have enough other options, whether it's prolotherapy, platelet-rich plasma, or even bone marrow stem cells, that we should be able to avoid things like high-dose steroid injections. So the next type of kind of orthobiologic to talk about are your own stem cells. These are the main cells that drive repair after an injury. Again, please use your own cells, not somebody else's. Bone marrow-derived stem cells are what's legal in the US. Fat stem cells are not. You can utilize fat or adipose for structural support, but the actual enzyme that you need to break down the fat into just a high concentration of your own stem cells is considered illegal by the FDA. They have concerns about utilizing that in humans. There is some evidence in overseas studies that is actually helpful treatments, but not legal in the United States. So please, if you're getting a stem cell treatment, utilize your own bone marrow-derived stem cells. Amniotic or umbilical cord cells, you don't hear as much about that nowadays because the FDA and FTC have cracked down on clinics that have been utilizing it because they've been falsely marketing those as a stem cell treatment when there's no living cells. You may also hear about IV stem cells in other parts of the world. Understand that there's really very limited evidence that these work for orthopedic conditions. From a common sense standpoint, if you have platelet-rich plasma injected back into your body via an IV, you're just diluting the platelets back into normal blood. If you're getting bone marrow concentrated stem cells injected via IV, the chance of getting to your joints is very low. When you inject it into a vein, that vein gets back into your heart, then goes through the lungs. When it's going through the heart and lung system, it'll get caught up in that sort of network of cells where it won't actually get to the joints. So maybe there's some benefit to using this for other organs, but for joints, very limited evidence of that. So other common questions that I hear, can we treat advanced arthritic cases? So we can improve pain and function, even in advanced arthritis. But can we improve what your X-ray MRI images look like? In advanced arthritis, probably not. If you've had something for decades, probably not. We probably cannot reverse what that MRI image looks like. If you've got a tendon tear that's less than 2 centimeters or a ligament tear that's less than 2 centimeters, we can actually improve that dramatically. And we have image cases where we can actually show that the tendon or ligament itself kind of refills in and sort of gets healed like that. If you've got swelling in a joint, we can improve that. If you've got swelling in the bone in an arthritic joint, we can actually improve that. That actually correlates very well with pain. If you've got a condition called avascular necrosis, where the blood supply to the bone is getting overly damaged, yes, we can treat that as well. So common question I get is, can we treat bone-on-bone arthritis? And simple answer is yes, we can. For pretty much all joints, and one exceptions are hip arthritis, where that's much more challenging. But even if you've got advanced arthritis, understand that wear and tear arthritis is a biologic condition. It's not just a picture on the wall. So a common thing that I see is someone who's got advanced arthritis in the knees has been told that they have bone-on-bone arthritis, and yet they can still bend their knee almost fully, right? So there's obviously still a cartilage interface there, and that kind of person can still get a 65 to 70% improvement in terms of pain and function. So if your goals are, can we improve your pain? Can we improve your function? Great. We can still all do all those things. Can we help you avoid surgery? Yes, we can do that. Can we get you back to doing the activities that you enjoy? Yes, we can do that. Can we get your imaging to look differently? No, not necessarily if you've got more advanced arthritis. I think if your goals are to improve how your x-ray looks, that's going to be hard. I think you're focused on the wrong things at that point. The reality is the most common thing that I see is a person who comes in with pain in one knee, they've had x-rays of both knees done, and the knee that doesn't hurt looks worse on x-ray than the knee that does hurt. So the images do not tell the whole story. So can we treat ligament and tendon tears? Unfortunately, again, we don't have our images up here to show you, but some nice images of treating an ACL tear case of a 28-year-old man, a butcher, who injured his ACL while playing recreational volleyball, full thickness tear, utilizing his own bone marrow stem cells, not only gave him great pain relief and back to his full normal function. On his MRI, you can tell how the ligament has healed back normal. Another case of a general contractor, 57-year-old, who we had treated 7-8 years ago with his own bone marrow stem cells for his rotator cuff tear. He has a full thickness tear, a gap in the tear on ultrasound. And by using his own bone marrow cells, we have that gap has filled in, right? And he's doing great. We actually gave him a booster PRP treatment a couple months ago, just to kind of keep the treatment going and keep his results going. Great example of where you can have something that does very well long term. You may need like a booster treatment at standpoint, and someone will do well. Let's catch up with some questions here. It's a great question. How many treatments are needed? A lot of this depends on the person. Number one, I don't recommend like a set number of treatments. There are folks who I know will do sort of 3 for knees in particular, because that's what you're asking about, who will do 3 treatments once per week for 3 to 5 treatments. They get that from the world of utilizing gel injections for knee arthritis, which is a very mild treatment. And when they're doing that with platelets, they're utilizing a very low dose of platelets, platelet-rich plasma. That's why they're doing that. That's not really adequate for getting a good result longer term. What you want is a higher dosage. And the reason why is when you use a higher dosage, you get a better impact longer term, but you also have more inflammation up front. So you wouldn't want to be dosing that week after week. It's just not comfortable in someone. And so what I normally tell people is, okay, get treatment on day 1. Let's see how you do for the next 3 to 6 months. And if you're still doing well, wonderful. But if you're plateauing and you're not at your goal, then let's talk about a second treatment at that point. So generically, what we'll tell people is that it can take, depending on your issue, right? If you're doing platelets, it can take anywhere from 1 to 3 treatments over the next 12 to 18 months to kind of get you to a good level. But again, for most people, I think you give them some time and you see how they do over time. Good question. So the next key concept to understand is interventional orthopedics. This is the idea of utilizing image guidance to treat orthopedic injuries. Again, unfortunately, we don't have pictures here. I'll actually give you a link at the end of this to see some prior webinars that we've done where we go through some of those pictures. But the idea being that you can hit very specific tissue deep in the body with great results. Shoulder labrum, a knee ACL, a spine kind of injury, like you can hit very deep tissue and get great results when you're using ultrasound and X-ray guidance. Doing it blindly palpating, you're not going to be able to do that. But with image guidance, and that's called interventional orthopedics, you can do that. Great case study that's worthwhile discussing is of a 41-year-old patient that I had, a chef, on his feet for 13, 15 hours per day, developed some early wear and tear arthritis, but more importantly, had what's called avascular necrosis, which means that the bone in the ankle is starting to lose blood supply and starting to die. You do nothing about that, that bone will get destroyed. The cartilage underneath it will get destroyed as well. And what we did in his case, under X-ray and ultrasound guidance, was injected his own bone marrow stem cells into the joint, the ligaments, and even to the bone itself. his MRI imaging 6 months later, and he's doing great from like a functional standpoint, standing during his entire shift at work, as well as now his MRI shows that that prior avascular necrosis has basically receded. You no longer have that death in the bone. So just another great way how we can utilize low risk treatments to really help people recover, heal, optimize their conditions. Regenerative medicine treatments offer safe and effective solutions for your pain. And again, please put in your questions. We'll keep on answering them. And after we're done, if you've got additional questions, you can always go to chicagoarthritis.com or to any of our social sites and contact us. In the chat section on the Zoom call of this, you can see all the different ways you can actually schedule an appointment with us, whether that's through the website, writing to us on the social sites, emailing us, or even directly contacting us through our scheduling app to schedule directly with us. So is this too good to be true? So we have evidence that goes back quite a long ways now. So Philip Yu, French surgeon, orthopedic surgeon, has data for knees and shoulders that goes back to the mid-1990s. The Regenix Network has data that goes back to 2005. My personal experience is that it goes back to 2008. So, I have colleagues that'll say, probably 10 years ago, were saying they didn't think these treatments worked. And now those same colleagues are saying they think it works, but they're not exactly sure. And the key here is that, these treatments in this field, it's not new. It's rapidly developing for sure, but it's not new. Work with people who've got experience. There's right and wrong ways to do these treatments. And your expectations of results and your candidacy should be grounded in reality and evidence-based medicine. I think that comes by working with people who are experienced with what they're doing. How long do results last? So, Regenix has data that goes over 15 years, actually 19 years now. Philip Hernigue has data that goes over 25 years, that goes back to mid-90s. What I tell people is think conservatively, however. For a chronic condition, expect repeat treatment at some point a few years after initial treatment. So if you're getting a platelet treatment, expect that you may need another platelet treatment 2-3 years down the line. For bone marrow, the data shows that people generally do well for at least 5 years. Some people do better longer. Some people do a little bit less as long. What I tell people with more chronic arthritic issues is that you probably need a booster treatment a couple of years after. For people who have more advanced issues, and maybe in 1 year. So it just depends on the person. But what we know about treatments is that there's a slow progressive improvement. At some point, you'll start to plateau. If you're at your goal, you continue to follow. And if you start to regress, you don't wait till it comes back to zero. Essentially, you treat it when it's starting to regress, and now you're stair-stepping to a higher level beyond that. The key things here are stability response, maintaining response, and then stair-stepping to a higher level if needed. The best ways to maintain results after treatment include the following. Number one, improve your biomechanics, work with physical therapy, work on posture, strengthening, use the appropriate joint supplements. Again, repeat treatment is additive to the initial treatment if needed. Maintain your ideal body weight. You can reduce for every pound you lose, you reduce the stress on the lower back and the legs by 4 pounds. So that's a key part of this if weight loss is required. Improve your metabolic health and inflammation. That's a key part of this, actually. I think the more and more we're starting to realize the importance of metabolic health, that means how well is your body handling blood sugar, blood pressure, cholesterol, all those things long term. If your metabolic health is poorly controlled, lead to more inflammation. Control those as well. That's important enough where we've actually started our own physician-assisted weight loss program, because I think that does help patients out as well. So good question. Somebody asking about cost and upper age limit for treatment. From an age standpoint, there is not an age limit for most areas that we treat. All right. When it comes to hips, what we guide people is that, look, if your age is over 65 and if you've got advanced arthritis, then your chance of getting a good result is probably a 1 out of 3 chance. That's a harder one to recommend. So normally in those cases, we'll recommend hip replacement surgery. Everything else that we treat, however, age is not a restriction here. Ideally, we'd all be 20 years old. The reality is that that's that's not who comes into the clinic for injuries normally. Our average patient is probably 65 plus, but we treat people everywhere from late teens to up into the 90s, and age does not really seem to make a difference in terms of outcome. The one exception being hips. In terms of cost, these treatments are not routinely covered by insurance. The one exception is that there are roughly 3,000 companies in the country that currently have added Regenerative procedures to their benefits plan. If your company is self-insured, which is most large companies, and you have the ear of someone in either HR or the executive suite, it's worthwhile getting them to look at regenexcorporate.com to see if they want to add this to their benefits plan to not only help out employees, help themselves out, but also reduce their cost of care. Talking to those folks, they can go through with you the dramatic reduction in cost of care by including these kind of treatments compared to just going for surgery. In terms of cost estimates in the US, here's what you should expect. For something like dextrose prolotherapy, which is a very mild regenerative medicine treatment, roughly $650 per treatment. For platelet-rich plasma, you'll see pricing at around $2,500 plus per treatment, depending on number of areas and area that's being treated. Utilizing your own bone marrow stem cells, roughly $7,000 plus per treatment as well. The keys to determine value are, again, is your physician and is the clinic, are they regenerative medicine experts? Are you receiving a real stem cell treatment or something that's mislabeled, like amniotic or placental cord treatments? And keep in mind that these are in-office procedures. And so you can avoid hospital and surgery center facility fees that tend to kind of dramatically ratchet up costs as well. Good questions. So again, I think keep in mind what makes a regenerative medicine expert is really going to be folks who have a proper focus on your musculoskeletal health, doing this non-surgically with image guidance. They know that this is the preferred first-line option rather than steroid injection, the nerve blocks. They're going to give you a personalized plan rather than a one-size-fits-all plan. They understand the concept of prolotherapy and being comprehensive in treatment, not just injecting the joint. If you've got, let's say, knee arthritis and they're only injecting into the knee joint and they're not treating all the other soft tissue elements, they're really missing a great opportunity to improve things longer term. They should be transparent regarding your results and candidacy. They should follow you long term. They should be able to guide you through the process. Just kind of closing up, but here at Chicago Arthritis, we're focused on non-surgical treatment of your arthritis, tendinitis, increase in back pain, starting with an evaluation, looking to see if you have inflammation, instability, asymmetry, any neuromuscular issues, trying to correct with low-risk interventions, if possible, to begin with. That can include just exercise and supplements. Not working, then escalating to regenerative medicine treatments, utilizing the best cellular treatments possible from your own body, a plan that is specifically tailored to your condition and needs, and delivering cells at the highest level of image guidance. If interested in getting evaluated, again, you can see in the chat section, but you can contact us either via the website, chicagoarthritis.com. You can email us at admin@chicagoarthritis.com. And if you've got access to the chat section, you can even see our scheduling app where you can schedule with us directly as well. Wonderful. Well, I'm going to hold tight for just maybe another minute or so to see if there's any other questions coming in. Thank you very much. Appreciate that. Wonderful. Listen, everybody, I appreciate your time. If you've got questions after we're done, again, please just contact us in any way that is convenient for you. You'll get a copy of this recording after we're done. You can share that with family, friends, or colleagues. You can rewatch yourself if you'd like to. I'll also give you on the YouTube site, you can actually see some of the prior webinars as well if you want to catch some of the PowerPoint slides as well. And until we connect again, I'd like to thank everyone. Please stay healthy and safe and have a good day. Thank you. Bye-bye.